Hi, this is Lois Haggard. I manage the Community Health Assessment Program in the New Mexico Department of Health. This is part 3 of the Community Health Assessment video series. In part 2 of the series, we talked about using objective information, such as incidence of death and disease, to indicate a population's risk for various health outcomes. A lot of people get kind of itchy when we start throwing the word data around. But the word data just means factual information. In community health assessment, we use data to understand risk for various outcomes so that we can plan effective ways to reduce risk, improve health, and reduce health disparities. In this video, we're going to talk about where the data come from. Death data are frequently used to assess risk. Death data can be used to calculate overall life expectancy and years of potential life lost, which is a measure of premature mortality. Life expectancy and all-cause death rates tell us there's an overall health disparity, but they don't give us clues on what we can do to improve community health and reduce the disparities. For that, we need to dig deeper into the causes of the disparity. So both death rates and years of potential life lost can be examined by cause of death to offer clues into the causes of disparity. Life expectancy from birth by New Mexico Health Region shows that Northwest and Southeast health regions have lower life expectancy than the other three. We can look at cause-specific deaths in those two health regions, and we can see that unintentional injury deaths, which are largely due to motor vehicle traffic crashes, drug overdoses, and falls, have a large contribution to the overall death rates. But where do those data come from? The death data come from the death certificates of persons who have died. All states in the U.S. use a standard death certificate. States can collect additional information, but all states collect the standard minimum information. The certificate includes a demographic characteristics section, including age and county of residence at time of death. The funeral director collects that information from an informant who is typically a close relative and enters the information into the state vital records computer system. Here are some of the socio-demographic characteristics collected by the decedent's proxy: education, race, and Hispanic ethnicity, and also occupation and injury. The cause of death information is provided by the attending physician. He or she certifies the death and reports the causes, including the underlying or immediate cause of death and any important contributing causes. The certifying physician writes in the causes of death in the text fields on the form. All states send their death certificates to the National Center for Health Statistics, or NCHS, which is a part of the Centers for Disease Control and Prevention. Data from birth certificates can tell us about maternal and infant health and also about access to health care. Birth certificates, like death certificates, contain a minimum set of information, including identifying information for the child and the child's mother and father, and socio-demographic characteristics of the infant's mother and father, including education level, race, and Hispanic ethnicity. The identifying information and the socio-demographic information is provided by the mother and usually the father. Most hospitals use a worksheet or questionnaire that the parents complete while the mother is in the hospital. Birth certificates also contain information about the risk factors and medical procedures related to pregnancy and delivery, and information about the health status of the newborn. The medical and health status information is from the infant's medical record. A hospital staff member called a birth clerk enters the information into the state vital records computer system. State vital records systems are used for more than health statistics. In fact, one of the reasons those systems are so complete and of such high quality is because of their use for purposes other than health assessment. For instance, the Social Security Administration uses death records to know when to stop Social Security payments to deceased persons or to transfer benefits to a surviving spouse. Birth certificates are a key form of identification and proof of U.S. citizenship. Before the 1980s, just about the only data we had for community health assessment were the birth and death certificates. So we knew about a person's birth, and then we didn't hear about them again until they died. We didn't have much state or county level information about what happened in between. Then in the 1980s, the CDC and the U.S. Department of Education started encouraging and sponsoring health surveys for states that measured health status and risk factors. Now we have a number of health surveys, chief among them being the Adult Behavioral Risk Factor Surveillance System, or BRFSS survey. We also have the Pregnancy Risk Assessment and Monitoring Survey, or PRAMS, which is a survey of women who recently gave birth, and the Youth Risk and Resiliency Survey, or YRRS, survey of high school and middle school students. These surveys provide a wealth of information about lifestyle and behaviors like cigarette smoking and alcohol use. We also get data from the health care system. These data are primarily from hospitals at this point, although data from physician office visits is expected to be available in the not too distant future. For the state licensed hospitals, data from both inpatient hospital stays and emergency department encounters are collected on forms whose primary purpose is to invoice patients and insurance companies to collect payment for services. Since the billing forms contain information on the patient's diagnosis and any procedures that were performed, they also provide information for community health assessment. Then there are the notifiable diseases. Every state has a list of diseases that are required by law to be reported to the state health department. There is a minimum set of diseases that are reportable in all states, plus each state can add to their law diseases of particular interest in that area. You can find the entire list of diseases and conditions for New Mexico on the New Mexico Department of Health website. Many of the reports of diseases come to the health department by way of laboratories in the state that may discover a positive test result for one of the conditions. Depending on the disease or condition, the health department may contact the patient and also the patient's physician to gather more information on the situation. For instance, for Zika virus, we would want to know if the patient had traveled to Latin America recently. It is of great interest to the department to know whether Zika virus is being transmitted in New Mexico. Infectious disease epidemiologists at the state and local health departments track disease incidents and investigate the causes of disease outbreaks to minimize the potential contagion and overall danger to public health. The goal of rapid response is to eliminate the source of the disease and prevent further illness and death. Depending on the disease and the situation, the information collected by the department may be more or less complete. Cases reported solely through laboratory reports will most likely have little detail on the individual. But if a disease outbreak was investigated, those cases will have more information than others for the same disease that were not associated with a cluster or outbreak. By the way, immunization is one of the most cost-effective and successful public health interventions in history, and high rates of a vaccine-preventable disease is an indication of low immunization in those areas. Disease registries are databases that contain information on a specific condition that has been collected from a variety of sources, such as hospital records, birth and death records, doctor visits, and other places. Some of the most rigorous disease registries in the U.S. are the state cancer registries. Although not everyone may consider poverty and high school graduation to be traditional health measures, they are strongly related to health outcomes. In the last decade, there has been increased attention to these so-called social determinants of health, so don't overlook other state agencies like public education and children, youth, and families departments for health-related information. Finally, the U.S. Census Bureau is a rich source of information on communities. The American Community Survey, or ACS, has become a go-to source for demographic characteristics. You can find all kinds of cool information for counties and census tracts, and in New Mexico we have ACS data for small areas too. Here's a little story. A policeman sees a man searching for something under a streetlight and asks what the man has lost. He says he has lost his keys, and then they both look under the streetlight together. After a few minutes, the policeman asks if he's sure he lost them here, and the man replies, "Well, no, he lost them under his bed." The policeman asks, "Why is he searching here?" and the man replies, "Well, it's dark under my bed. This is where the light is." Okay, well, the point of the story is that we can only find data and information where we look for it. We have a variety of data sets and we try to take a comprehensive view, but resources in public health are finite and we don't have data for every community and every need. We need to realize that whatever data we examine only provides a part of the picture. We need to use objective data along with subjective reports from the community, and also use common sense in assembling a holistic view of health status in the community. In summary, we collect data and information on community health from a variety of sources, each with its own inherent strengths and weaknesses. It helps to know where the data come from to interpret findings from that data source. The data sources we can examine may not tell the entire story about a community's health, but we can and should use health data to enrich our understanding of health in a community. This is the end of part 3. The next video in this series is about using death and disease rates in community health assessment.